Hi, everyone. I'm Amy Hajari Case, the Chief Medical Officer at the Pulmonary Fibrosis Foundation. In May, members of our medical team and staff attended the American Thoracic Society's 2025 International Conference in San Francisco. The ATS conference is one of the largest scientific meetings focused on pulmonary critical care and sleep medicine in the world. Nearly 14,000 attendees gather every year to hear updates in their fields, to present their own work, and to network with colleagues from around the world. This year, in the field of pulmonary fibrosis and interstitial lung disease research, we heard about new clinical trial results, new guidelines, and new findings from basic, translational, and clinical research studies that add to our understanding of ILD. My Pulmonary Fibrosis Foundation medical team colleagues, Dr. Lee and Dr. Flaherty, and I are excited to share with you some of the exciting new updates from the ATS meeting.
My name is Kevin Flaherty. I'm a pulmonologist and one of the medical advisors for the Pulmonary Fibrosis Foundation. And it's my pleasure to present to you data that was presented at this year's 2025 American Thoracic Society conference, looking at the study of Nerandomilast in patients with idiopathic pulmonary fibrosis and patients with progressive pulmonary fibrosis. Nerandomilast is an oral inhibitor of phosphodiesterase B. And just as a little bit of a background, when cells get signaled, they use molecules such as cyclic AMP as second messengers to tell the rest of the cell to do things, such as make proteins, for instance, that may be inflammatory or may decrease inflammation, or similarly may increase or decrease fibrosis. And phosphodiesterases are a large group of families of enzymes that break down these second messengers like cyclic AMP. These phosphodiesterases can be located by family type in different types of organs or cells. And in the case of phosphodiesterase 4B, it tends to be located to lung and immune cells, such as bronchoalveolar macrophages or peripheral blood monocytes, T cells, B cells, or neutrophils. When phosphodiesterase B inhibition has been studied in knockout models in animals, it was shown to decrease airway inflammation and hyperactivity to allergens, decrease neutrophil recruitment to sites of injury, and inhibit transforming growth factor beta myofibroblast differentiation. So based on these preliminary animal models and the effective inhibition of phosphodiesterase 4B, it was felt that it made sense to study this in patients with pulmonary fibrosis, where this molecule may have anti-inflammatory and antifibrotic effects. The Nerandomilast studies in IPF and progressive pulmonary fibrosis there were two separate studies, but had very similar study design. These two separate phase 3 randomized placebo-controlled trials in IPF and PPF randomized patients 1:1:1 to receive either 18 milligrams of the study drug, 9 milligrams of the study drug, or placebo. Patients were allowed to be on background antifibrotic therapy, and randomization was stratified to balance those groups. So in IPF, they could be on nintedanib, pirfenidone, or no antifibrotic therapy. And in the case of progressive pulmonary fibrosis, they could be on either nintedanib or no antifibrotic therapy. If patients happen to be on pirfenidone, they were not allowed in the trial because pirfenidone does not have an FDA approval for progressive pulmonary fibrosis. The primary endpoint in each of these studies was the change in forced vital capacity over 52 weeks. Key secondary endpoints looked at composites or individually acute exacerbations of pulmonary fibrosis, respiratory hospitalizations, or death, and other secondary endpoints included patient-reported outcomes and diffusion capacity for carbon monoxide. Key inclusion and exclusion criteria overlapped but were different between the two trials. In the IPF study, patients had to have a diagnosis of idiopathic pulmonary fibrosis, be 40 years or older, have lung function with a vital capacity of at least 45% of predicted, and a diffusion capacity for carbon monoxide of at least 25%. If they were on antifibrotics, they had to be on that for at least 12 weeks, and they had to be on less than 15 milligrams of prednisone. In the case of the progressive pulmonary fibrosis study, they could not have IPF, but had to have some other type of interstitial lung disease with similar pulmonary function criteria as the IPF study, at least 10% fibrosis on CT scan, and progression of their fibrosis has declined within the past 2 years of at least a 10% decline in forced vital capacity, or a 5 to 10% decline in forced vital capacity associated with worsening symptoms or worsening fibrosis on CT, or worsening symptoms in C-type fibrosis. If they were on nintedanib, they had to be on a stable dose for at least 12 weeks, and other types of immunosuppression listed on this slide were not allowed in the study. Who were the patients that were in the IPF study? I'll look at this study first and then follow up with the PPF study. For in the IPF study, most of the subjects were male, over 80%, with an average age of around 70. They had disease for about 3.5 years. Their vital capacity was almost 80% of predicted, DLCO around 50% of predicted. About 45% of patients were on background nintedanib, about 30% on background pirfenidone, and around 20 to 25% of patients were using supplemental oxygen. This slide shows the outcomes of the primary endpoint change in FVC. On the top left is the overall trial population, showing a slower decline in lung function on 18 compared to 9 compared to placebo patients. On the top right are patients receiving receiving no background antifibrotic therapy, also showing slower decline in lung function with study medication compared to placebo. The bottom left shows patients taking nintedanib as background therapy, and even with this combination, there was still a slowing and decline in lung function. Interestingly, on this slide is also the bottom right panel, which was showing patients taking background pirfenidone therapy, where here you see that there was no difference between the 9 milligram nerandomilast group and the placebo, but there was still a difference in the 18 milligram nerandomilast group. This suggests that there may be a drug-drug interaction where a higher dose is required if people are on background pirfenidone therapy. In terms of key secondary outputs, looking at composites such as the first exacerbation of pulmonary fibrosis, hospitalization, or death, or if you broke those up into just exacerbation and mortality, hospitalizations, death, or categorical change in lung function, there is no significant difference between the nerandomilast groups and placebo groups. The most common side effect was diarrhea. It occurred overall in 41% of the patients on nerandomilast 18 milligrams, 31% on 9 milligrams, compared to 16% on placebo. However, this did seem to be influenced by if you were on background therapy, particularly nintedanib, with the highest incidence of diarrhea being on patients treated with nintedanib, and less diarrhea on those with no background therapy or those treated with pirfenidone. Changing gears to review the data from the progressive pulmonary fibrosis, the baseline characteristics are a little bit different. There were less males in this group, around 50% compared to 80% in the IPF trial. Age was a little bit younger, around 66 years. A little bit longer time to diagnosis, from 3.9 to 4.6 years. Lung function was similar, with FVC being 70% predicted, DLCO around 50% of predicted. Around 40% of patients were on background nintedanib. There was no background pirfenidone, as it's not FDA approved in this disease state, and around 25 to 30% of people were using supplemental oxygen. What were the types of interstitial lung disease diagnoses that made up the study? Well, about 25% had autoimmune-associated interstitial lung disease, around 20% had hypersensitivity pneumonia, 20% had unclassifiable disease, 20% had NSIP, and the remainder of the patients had other forms of smaller numbers of different types of interstitial lung diseases. Similar to the IPF study, nerandomilast slowed the decline in lung function in patients with progressive pulmonary fibrosis compared to placebo. This was seen in the top left and the top right, either by bar graphs or continuously, with both 18 and 9 milligrams of nerandomilast slowing the decline in lung function compared to placebo. The bottom panels, these also show that the effect was present whether patients were not taking background nintedanib, the bottom left, or if they were taking background nintedanib in the bottom right. Interestingly, in this study, the key secondary endpoints showed either strong trends or statistical significance with a benefit for nerandomilast over placebo. If you looked at the top, the key secondary endpoint was a composite of all endpoints. These were not significant, but the trend favored nerandomilast. This was similar when you looked at acute exacerbations of ILD or mortality, respiratory cause mortality, And interestingly, when you looked at mortality alone, it was statistically significant for both doses of nerandomilast compared to placebo. The side effects were similar in the IPF trial, with diarrhea being the most common, and diarrhea being more common in patients that were taking background nintedanib compared to patients that were on no background therapy. So in summary, nerandomilast slowed decline in forced vital capacity compared to placebo in both idiopathic pulmonary fibrosis and progressive pulmonary fibrosis. This was effective in patients that were or were not on background antifibrotic therapy, and that there is likely a drug-drug interaction with pirfenidone requiring a higher dose. Key secondary composite endpoint of acute exacerbation, respiratory hospitalization, or death was not significantly different in the IPF study, but there was a trend for significance in progressive pulmonary fibrosis with statistical significance met for mortality. At this time, these data are being reviewed by the FDA, and we're awaiting a decision regarding potential drug approval. Thank you.
Hi, everyone. My name is Joyce Lee. I'm a senior medical advisor for the Pulmonary Fibrosis Foundation, and I'm going to be sharing with you an ATS clinical statement that was just released on interstitial lung abnormalities. So this is the document. The American Thoracic Society meeting met in San Francisco, and they released these guidelines on how to approach and evaluate interstitial lung abnormalities, and they were formally published in the American Journal for Respiratory and Critical Care Medicine in July of 2025, so really hot off the press. So in order to talk about this statement, we have to talk about what is an interstitial lung abnormality, or ILA, first. So an ILA is essentially when a chest CT scan shows findings suggestive of a problem in the lung tissue itself. So this can be characterized as more than 5% involvement of radiologic features such as ground glass opacities, reticular abnormalities, traction bronchiectasis, or honeycombing. Often they're found what we call incidentally, so you're getting a chest CT scan for other things, particularly the heart or perhaps lung cancer screening. And these findings, is important to remember that they are not specific, but in the right clinical context are important and could suggest an interstitial lung disease. Now, interstitial lung abnormality is not equivalent to interstitial lung disease. It's often thought as a precursor to interstitial lung disease. But again, important to remember that not all interstitial lung abnormalities become an interstitial lung disease. And in this statement, they also define what should be considered an interstitial lung disease in those who have an underlying interstitial lung abnormality. And you can see here that with the chest CT features of an ILA, if a person has symptoms or any lung function test abnormalities or extensive disease by imaging, or if they, for some reason, have lung tissue that shows the presence of an interstitial lung disease pattern, those people are considered to have a disease, and interstitial lung disease, and not an ILA. So you may be wondering why they created a statement like this, and there are two main reasons why our society decided it was important to create a statement. First is that ILAs are associated with increased respiratory symptoms, an accelerated loss of lung function, progression of radiologic fibrosis over time, and has been associated with an increase in all-cause and respiratory-specific mortality over time. And the second main reason they created this statement is because there is no standard clinical approach to identify people with these radiologic findings. There have been differences in discrepancies in definitions, a lot of strange terminology, which is not new to our field, and a lack of data to guide our approach. As such, the society decided to create this clinical statement on ILAs, and they addressed three main areas: screening, baseline assessment, and follow-up assessment. And I'll go through their recommendations for each of these areas. So in terms of screening, the authors of this statement recommended the following. So to systematically assess the presence of ILA in smokers who are already undergoing lung cancer screening. Second, that a baseline CT scan to assess for ILA or ILD in adults with an underlying autoimmune disease associated with an increased risk of ILD. This includes people who have rheumatoid arthritis, scleroderma, myositis, mixed connective tissue disease, Sjogren's, and overlap connective tissue disease. In addition, they also recommended CT screening for ILA or ILD in adults who are over or equal to the age of 50 years and are also a first-degree relative in families with pulmonary fibrosis. So FPF, or familial pulmonary fibrosis, is defined by having two genetically related first or second-degree relatives with fibrotic interstitial lung disease. And finally, they did not recommend genetic testing for MUC5B or telomere length as part of the screening process. So what does that mean for you? So if you are already undergoing a lung cancer screening CT scan by your physician, then the radiologist should specifically comment about the presence or absence of ILA and/or interstitial lung disease. Secondarily, if you have the following risk factors, you should discuss getting a screening CT scan to assess for ILA or ILD. So if you have an underlying autoimmune disease, as we mentioned previously, or if you're a first-degree relative in a family with pulmonary fibrosis and you're above the age of 50 years. Now we'll move on to the second section, which is baseline assessment. So every person who's had a screening CT scan for ILA, and if you're found to have ILA, you should be assessed for symptoms, whether for the presence of cough or dyspnea on exertion. Baseline pulmonary function tests should be obtained, and they recommended against the routine collection of lung tissue specimens, and they do not routinely recommend genetic testing for MUC5B or telomere length measurement. And the final area in which they addressed was the follow-up assessment. So if ILA is present on the screening CT scan, they recommend a follow-up CT scan 2 to 3 years after your baseline scan. They did note that earlier follow-up may be appropriate depending on the clinical context, and the clinical context might suggest features that are associated with an increased risk for progression of these ILAs. And in this manuscript, they provide a handful of features, both demographic, genetic, and imaging features that could increase your risk for progression and change that follow-up timeline. Of course, this is an area that we are just coming together on in terms of definitions and terminology and standardized screening, but there's still a lot of ongoing areas of uncertainty and data needed for research. Some questions that have come up include, what about family members of those who have idiopathic pulmonary fibrosis without meeting the definition for familial pulmonary fibrosis? Are there specific scenarios in which genetic testing would be recommended? Is there a role for treatment of these ILAs before they become an interstitial lung disease, and many others? So hopefully the future will develop the data to answer some of these questions. So in summary, this statement suggests that we identify and screen for ILA in certain high-risk individuals. Baseline assessment should include symptom assessment and lung function in those who are found to have ILAs. Genetic testing is not recommended in the screening process or in the baseline assessment of ILAs. And if an ILA is present, individuals need to be followed over time to assess for the development of interstitial lung disease. And the exact frequency and type of follow-up still remains unknown. And that's it. Thank you.
The PFF supports research in pulmonary fibrosis and interstitial lung disease through several mechanisms, including the Care Center Network, through the PFF Registry, and through our PFF Scholars Program. Many of the ILD-focused presentations at the ATS meeting were given by Care Center Network faculty and staff, and our PFF scholars alone presented more than 20 posters, abstracts, and podium talks. I'd like to share with you a few examples of research by our PFF scholars, and that was supported by the PFF Registry. First up is a project by Sarah Kahn. She's a pulmonary and critical care fellow at Johns Hopkins University and a 2025 PFF scholar whose research work focuses on pulmonary hypertension in the setting of interstitial lung disease. One of the research studies that she presented at the ATS conference compared outcomes between more than 360 patients with connective tissue disease-related ILD and two different types of pulmonary hypertension, one that is more related to blood vessel abnormalities, the vascular phenotype, and one that is more related to lung tissue abnormalities, or the parenchymal phenotype. When Dr. Khan and her colleagues, what they found was that in this group of patients, those with the parenchymal phenotype were at higher risk for clinical worsening, including hospital admission, worsening function, lung transplant, and dying. The distinction between the two types of pulmonary hypertension in the setting of ILD that's related to connective tissue disease is sometimes difficult, but important to determine because of the differences in outcomes and the need for different therapeutic approaches. And this graph is just looking at the survival curve between those two different subclassifications of pulmonary hypertension. Scott Matson is another of our PFF scholars and assistant professor of medicine at the University of Kansas. His research interest is around the use of multi-omics technologies and techniques to identify risk factors, and biomarkers for ILD. But first, before I get into his project, I just wanted to define omics for you. You may have heard the word genomics, which is the study of the genome or the entire set of an organism's genes. Well, there are other omics fields that study large sets of other biologic molecules. For example, proteomics studies large sets of expressed proteins, and transcriptomics studies the RNA transcribed from a genome. So keep that in mind in the future when you hear about the different types of omics studies that are being published. So back to Dr. Matson's research. This study uses proteomics, an analysis of proteins in the fluid, in this case, collected from the lungs of 65 patients during bronchoscopy, to distinguish between different types of interstitial lung disease, in this case, idiopathic pulmonary fibrosis, and something called interstitial pneumonia with autoimmune features, or IPAF, which is a type of autoimmune ILD. The analysis of proteins showed a significant difference in the proteins identified in the different groups, with the more inflammatory proteins expressed in the IPAF group, shown in red here on this graph, as compared to the IPF group, which was in purple, which didn't really express those inflammatory proteins. Dr. Matson and colleagues suggested that further research is needed to validate these findings that may help inform therapeutic strategies for patients with IPAF in the future. Next up are two studies that utilize the Pulmonary Fibrosis Foundation's registry as a data source for their projects. The first is from a collaboration between researchers at the University of Virginia, University of Michigan, and Weill Cornell Medical Center, and again used proteomics to help subclassify two different types of interstitial lung disease, in this case, idiopathic pulmonary fibrosis and connective tissue disease related ILD. So a large group of different types of CTD-ILDs that were lumped together. They used samples and clinical data from both the Pulmonary Fibrosis Foundation's registry and another study called Precisions to compare how a set of 37 proteins in the blood could be used to differentiate between IPF and CTD-ILD. They found that the proteomic signature, this 37 set of proteins in the blood, was able to accurately distinguish these when the distinction was compared with our usual method of multidisciplinary discussion for the diagnosis of these conditions. And it may be a useful tool in the future for interstitial lung disease classification. I'll show you here. These are survival curves and showing the multidisciplinary discussion diagnosis versus the classification by the proteomic signature denoted by PC37 in the connective tissue disease group and the IPF group, and they matched up pretty closely. Finally, the last study I'll share was an observational study that utilized data from the PFF Registry and also from Duke University's electronic medical records to identify more than 1,000 patients with IPF that were on antifibrotic therapy, either nintedanib or pirfenidone. They found that a little over 2/3 remained on their full dose of their antifibrotic therapy at 1 year, while about a quarter of them required a reduction in their dose, and less than 10% had to discontinue treatment altogether. What was interesting was that they found in this observational set was that those who reduced or stopped their antifibrotic dose did not appear to have different clinical outcomes, at least during the course of the data collection in the study, from those who remained on full dose of treatment.